have you here. So maybe just a brief introduction of our panel today. I'll start with my immediate left, Dr. Joseph. Kindly tell us more about yourself.
Thank you very much, Angel. My name is Emuron Joseph. I'm an emergency physician. I work in Katakwi General Hospital, that is in Eastern Uganda. I'm happy to be part of this session today, and I'm here to learn and share with the rest of the audience. I want to thank the audience for creating some time to be here with us. I look forward to a fruitful discussion.
Thank you so much, Dr. Emuron. Yes, Mr. Kalanzi.
This is Kalanzi from SMO Uganda. I'm Executive Director and founder. SMO Uganda is an organization working in ground prevention and water safety since 2011. We've established 9 community-based programs, and the reason is to have community responders who can respond in case of drowning. Thank you.
So happy. We're so happy to have you here, Mr. Kalanzi. We also have some of our panelists that are online. Dr. Michael Suuna Michael. Maybe Dr. Michael will be joining us shortly. Dr. Clark.
Sorry. Yes.
Hello, Dr.
Make me a host. Yeah, I can't. If you could make me a host such that the people are able to see me. I'm Dr. Michael Suuna. I'm glad to be here with all of you, those present at SEED and those online. I'm a senior medical officer working in Kalangala, an island district of 84 islands. I'm here today to present a case which we had in the islands. By nature of our district, we see a lot of drowning cases, so I'm here as an expert case presenter. Thank you.
Okay, so maybe Michael, you can show us a video. I think now you should be able to do that. And maybe someone has mentioned something about the audio. Can you hear clearly?
You can see me now.
Oh, nice to meet you, Dr. Michael Suuna. All right, and then finally, our other panelist is Dr. Claire Amaya. Please also introduce yourself and we get to know you. Maybe she has dropped off. We shall get her to introduce herself a little later. Okay, so we're going to continue. So now that we have made all our panelists, it's going to be a very interesting session. Sure. Just an icebreaker of it all, when I thought I was going to moderate this event, I also happened to be in Mombasa earlier this year. And as a person who can't swim, it's snorkeling. So this one, I feel like I might have been a candidate for maybe one of these emergencies. And I'm also here to learn and also to learn from all of you. So as we start the session, we'd like to have a pre-test and maybe get your expectations from this session. We're going to display a pre-test under the polls, under the Q&A. Kindly take some time and go through the pre-test just to get a baseline of your expectations. Can you hear me clearly? Yeah. All right, so the pre-test has been put up. Kindly let's go through it within 5 minutes. So as we're going through the pre-test, let's also get some of your expectations. You can Post them in the chat as we are continuing. Please post your expectations in the chat. Is everyone able to access the pretest? She's online now. Are you all able to access the pretest? I think it ended before. There are three posted it. Okay, so as you're continuing, I think Dr. Clara has been able to join. Kindly introduce yourself, Dr. Clara, for the audience to know.
Good afternoon, members. I am Dr. Mary Claire. I am a medical officer at Katakwi General Hospital. It's an honor to meet each and every one of you that has taken time to join this session. It's going to be very entertaining, very educative. So let's pay attention. Thank you.
Nice to meet you, Dr. Clara. Also, working on the background is Dr. Jacob Busingye, who will be taking our questions. Please introduce yourself, a brief introduction for Dr. Jacob.
Good afternoon, everyone. This is Dr. Busingye Jacob. I'm glad to be here. I'm an emergency physician, and I'll do as best as I can to answer the online questions. This should be an interesting session. Let us make sure we benefit from it. Thank you.
Okay, so thank you so much, Dr. Jacob. I think the poll has ended, and now we're going to move on to our first presentation for today. It's going to come from Dr. Michael Suuna. Dr. Michael Suuna, kindly take over.
Thank you. Allow me to share my screen. You can see my screen. Hello?
Yes, you can. Yes, Dr. Suuna, you can see your screen.
So, good afternoon, members. I introduced myself already. I'm going to present to you a case which we had of a 16-year-old boy who was hospitalized after near drowning in a swimming pool. He was rescued by the lifeguard from a depth of about 1.5, that's the deep end. And eyewitnesses reported that the drowning boy was unconscious and not breathing and had no pulse. The lifeguard quickly performed first aid by opening the airway and performed mouth-to-mouth breathing and started chest compression. After about 2 to 3 minutes, the boy started breathing, he coughed and vomited before he was quickly transported to the hospital in a private vehicle. When he reached the hospital, we did a primary survey. His airway had been compromised, so we did basic airway maneuvers, jaw thrust, chin lift. He had a respiratory rate of 30 and was desaturating at 80% on room air. Auscultation revealed that he had crackles and rhonchi in the middle and lower lobes. We gave him oxygen through the non-rebreather mask, starting at 8 liters per minute and decreasing to 6 to maintain SpO2 above 94%. In saturation, his BP was 105/55, but the ECG showed irregular rhythm with short-term atrial fibrillation that later converted to sinus rhythm and a pulse rate of 120. GCS, he had a GCS of 13/15. The pupils were equal and reactive to light and accommodation. He had no focal neurologies, and his RBS was 5.2 millimoles per liter. His temperature was 35.2. We did passive warming with blankets. In terms of sample history, significantly had cough, froth in the mouth and nose, and difficulty in breathing. He had no known allergies and no history of medication use. He was an ST student, no history of alcohol use, and no reported history of chronic illnesses. His last meal had been 4 hours ago, which was breakfast before the events. The head-to-toe examination, he had no injuries on the head, no deformities. I already mentioned that in the chest he had crepitations and rhonchi. The abdomen was soft, non-tender, and no masses, and he had normal bowel sounds. The limbs and the back were normal. We generated a problem list, and this included respiratory distress, basal crepitations and rhonchi, a decreased level of consciousness, hypothermia, tachycardia, and irregular heart rhythm. The investigations we did at arrival, I mentioned that he had an irregular heart rhythm. So the ECG features we saw were absent P waves, there were oscillating waves. The arterial rate was about 300 and the ventricular rate was 120. And this was seen in leads 2 and V1. This showed atrial fibrillation, but it spontaneously converted to sinus rhythm upon management. The chest X-ray showed spotty shadows in the middle and middle and inferior lobes. The costophrenic angles were normal. His CBC and RFTs were normal. So we made an impression of near drowning and a differential aspiration pneumonia. On top of the emergency management, the oxygen that we gave him, we also gave him antibiotics, ceftriaxone, Genta, and metronidazole, and started him also on IV paracetamol. Upon follow-up, day 5, the patient showed complete recovery, a chest X-ray was normal. We registered atrial fibrillation, supraventricular extrasystoles. So we did an echo, which showed hyperechoic left ventricular myocardium with restricted ejection fractions on the left. We gave him a beta blocker, IV labetalol, and advised him to avoid any kind of exertion. We later on did a disposition plan. So we discharged him on amoxiclav and a low dose atenolol. We advised him to see a cardiologist and to avoid physical activity, and educated him on drowning prevention. 2 months later, he came back with the heart function had improved, the fractional shortening of 34, and ejection fractions of above 45%. Thank you. I now take any questions on this case.
All right. Thank you so much, Dr. Suuna. Any questions? Feel free to raise your hand or put a question in the chat, unmute and ask a question. There is a question from Michael Apol. I would like to know the indications of that for the triad of antibiotics given to the patient. Same question as Simon Harithi. Indication of the antibiotics.
So we gave the antibiotics because of the history of vomiting and our differential aspiration pneumonia. So it was more or less a prophylactic intervention for the use of the antibiotics. Thank you.
All right, thank you so much. And then there is another question from Lily Collins. What was the instance of IV paracetamol in hypothermia?
Okay, so I mentioned that we warmed him passively with the blankets, but probably what I didn't mention is that he was complaining of mild chest pain, so we just wanted to give him a painkiller. Thank you.
Then we have another question that why give all the 3 antibiotics? Why not maybe say 1 or 2? Why give all 3 antibiotics?
Because this was an emergency case, we could not really determine the bacteriology. So we wanted to cover both the gram-negative, gram-positive, and anaerobes. So that informed our choice of the antibiotics. And obviously, because those are the common antibiotics that we have in our facilities. So the choice of antibiotic, a single antibiotic, was limited. Thank you.
All right, thank you so much. There's a question from Habib Matovu. How long did it take for the lifeguard to respond to the emergency?
How long the lifeguard to respond to emergency? I didn't get one part of it, please.
This has been hospital management, but when you say the lifeguard did chest compressions and recovered this patient from the water. So they are asking how long from the time of drowning to when the lifeguard was able to respond to this scenario, to this patient?
Unfortunately, I could not determine that time because we received the patient from the hospital, and that is the history that we did not take. Thank you.
All right. Okay, so we need to proceed to the next presenter. However, Dr. Busingye is going to continuously answer the questions that keep coming up in the chat. So feel free, and maybe after the next presenter, also feel free to put up your hands. We want to listen to your voices and interact, make it an interactive session. All right. So we are going to go on to our next presenter, Mr. Moses Kalanzi. Please. She's after. Yeah. All right. Thank you so much.
Thank you, Angel. Going to go through the approach to environmental agencies when we are looking at the rescue, on-scene management, and the transportation.
On-scene.
So here we look at risk. Why drowning such sessions are really needed in this country is because, as you can see, when we look at this water is covered by water, this in Uganda is really up there. In Uganda. So there's only justify why we need to have such topics in this session. And then the risk factor, which are the swimming, which is everywhere in Uganda now, and everywhere. At time X, you are going to have a drowning victim. And then also when you look at our setting, we lack such safety equipment and the use of CRP. So in this presentation, we look more trying to understand some of the effective rescue skills. And then also the highlight key on the scene management and strategies. And then we look at the safe transportation methods. And that's what we look at. Before coming to the rescue, there are a few tips that we want everybody to understand. And this is a very good time unless you are trained. So we advise everyone to be trained to rescue, for going to rescue. And also use of aids, and then such as rescue boats, and then other protection devices. So if you are not trained, kindly wait to go for rescue. We're now looking at the rescue. But before we go there, scientific explanation of drowning, which is when we look at the scientific explanation of drowning. So drowning is being explained as the process of experiencing respiratory impairment by submersion in water. Different outcomes, which can be suffering, mobility, and illness. That's why we are considering drownings to be drowning. So don't say this is near, this is primary, this is basic. Drownings and drownings because they have better outcomes and repercussions. So that's why we're saying that everybody who is in distress will recognize and then that person has a drowning victim. So here we are saying before the rescue, for shorter period. That's why we need to quickly identify and respond. And assess the situation and perform appropriate rescue. Once you've rescued the person, and provide the necessary care. So we'll
maybe I ask clearly, I think there is Claire. Someone has a hand raised. Or someone with a hand raised.
Hello, the audio coming through to the people online it's not clear at all. I think this is the complaint that is being raised. I think since Mr. Moses started talking, the audio has not been clear.
Can you hear me speaking clearly on my end?
Yes, I can hear you speak, but I think since Mr. Moses started speaking, we couldn't hear anything, those online.
Let me switch a microphone with you. Just hold it next to me. Just hold this.
Making sure to work.
Maybe try to ask if they can hear you.
So Mama would be up now. Sure. So I can move ahead.
Can you hear Mr. Kalanzi now?
Yes.
You can, yeah?
And then now.
All right.
So I was saying that drowning, it has got a scientific explanation, which is the process of experiencing respiratory impairment and submersion or immersion in liquid. So that means it can be stopped at any time because it's a process. That's why if it's not stopped at any time, it can lead into fatality, morbidity, and other things. So that's why it's very important to have people trained on how to stop the process. And this we call it rescue. Yeah. Before I had said that it's very important to understand before going to rescue. You must be trained to rescue. And these are things we talked about. Now here we are talking about what are the things to consider as you are going for rescue. When making the rescue, you must be quickly determine some critical information before you reach the victim using the stop, think, and act principle. And some of the things you need to ask yourself: does the victim appear to be active, which is responsive? It's something to consider. Then we also consider how do you safely enter the water? Where do you enter? So it's also very important. And then the rescue technique you will need to use. Also consider how many victims, the number of people who are involved, and is it likely to involve other respondents? If it's the case, then you need to activate the disposition plan for other people. Yes.
Maybe let's first pause there. Are you guys still hearing anything? Mine is
No,
clear.
the audio is not. The audio is not clear. We can hear you, but we cannot get Mr. Kalanzi very clearly. At the start, when you had rectified, seemed to improve, but then it iterated after half a minute. So the audio is not good. We can't get anything across.
I think Mr. Kalanzi should present from your computer.
Okay. All right. So maybe let him try using that one now, like that.
Okay. So, and now, Doctor, so now it's okay?
Yes,
Okay.
it's slightly better.
So we continue with that. I think here is better.
I think we can restart.
I'll proceed.
Okay.
Yes, those are a few considerations that we consider. And then another one is now the principle that really guides us as we go. Another slide. So we have the general steps that we follow when making rescue. And one is activate your emergency action plan. Two, hopefully we understand the emergency action plan. For each facility, we must have that action plan. And also on the community level, like whom to call, more assistance needed. So 2 is depress the emergency stop, like make sure the other activities ends, and then we aim at the rescue. 3 is now we head to the water, we enter the water, then the rescue operation begins. Another is quickly approach the victim. Once we enter the water, our aim is quickly approach to that victim. Approaching the victim, we perform the appropriate rescue. What's needed? And then we move the victim to the safety. You know, we consider where this victim seems to be safe. Remove the victim from the water, provide any additional emergency care needed, complete a report, a rescue report, and then we move on. So what happens after releasing? In most cases, you find that some of these people who are drowning, you don't need to entangle yourself. You can do something when you're out. And this, we call it providing an assist. This is where I don't enter the water, but I can send something, and then that person is rescued. It can be extensional assist, where I need to send whatever is next to me. Let's say we are in a boat, and we have got anything like a pole. How can I use that pole and send it to that person? It's more advisable that if you do not have 10/20, if you don't have a half of your body, 10/20 out, then don't go. So you need to have support from on board, and then you send the aid so that you are able to assist. Yes. Another slide. So water entries. So we've said that in providing assists, we don't take ourselves in. But there are also some scenarios where you will find that you cannot make an assist. You cannot really go there, minus, you cannot save a person if you've not gone there. So that's when we consider different entries, the stridor jump, the ease, you know, and then also there is the shallow, when somebody is next and the water keeps on going. So you define by yourself what entry will you be using. So it's better to understand the entry and what works when. After entering the water, it's very important to understand which life-saving strokes will you use. But all strokes, we aim at looking at the victim at all the time, because this victim, they change positions, anything changes along the way. So as you're approaching what we call strokes, the entry is the way you enter, and the stroke is how do you move towards that person. So we use life-saving strokes. That's why we say good swimmers are not good lifesavers, because in swimming, we use swimming strokes, which is butterfly, backstroke, breaststroke, you know, and they don't really go for rescue. Here you can see we use strokes whereby you are focusing on a victim. If at all it changes the position, you are able to see. When you get close to the victim, these people, they tend to change a lot of things, but you must keep in mind that my focus is only there. And once you are about to reach, communicate to the victim so that it's really aware that you are there. Yes. I want us to look at the few considerations that we call the 5R in rescue. And one is rescue. The rescue of the victim using several techniques, whatever you decide. Then another one is removal. How do you remove that person from the water? Another one is lender aid. After getting that person out of the water, how best? What can you do next? So is the person needs more care, the CPR, or on a recovery position, or assurance, because some of them, you know, you will find them crying, I almost died, where you just need to calm them down, you know. So, and then after we make the report clearly. Why do we need to report to make this report? And some cases you will find that once the ambulance comes, they will need to know what happened. So this report really helps us and also helps the crew on the ambulance to understand what was done since the incident happened. And it's also good for us. You know, once we are making our research, we are able to understand why. So, and the last R is release. So you can either let that person go home if you feel nothing will happen, or you release to the EMS team. So that's what we do. Yes, on there. So note that every person will respond. Note that everybody drowning will do what you want. For example, we had a big scenario in Uganda, a big accident, the MV Tempura. And the rescuer rescued some people, but when he went to rescue other people, they made him also drown. So there are many times where the rescuer also doesn't survive. So there are scenarios where we need to consider different rescue practices. And then here we are talking about responding to a responsive victim. So if if the victim is clearly responsive, then at time we don't even activate our emergency action plan, we go. But at time, if it's not, you do. So there is what we call grab and lift. This is a rescue used with the responsive adults in shallow water, where I'm really able to pull that person out. And then what we call front drive rescue. This is used when a responsive victim of any size on the surface, but has to be there. But again, there is what we call a front hug. This is normally when I come in front of you, and then I'm able to assure you, here is the rescue tube, here is the aid, and I'm able to get you. Then there is also a layer hug rescue. This can be used when a responsive victim of any side deep water and facing away, that somebody is the other side couldn't see you, and then you just have to pass the aid and you get the photo can clearly explain. Yes. And then, as I said, not everybody can be seen. There are those who are underneath. So we also need to consider about them. And then if somebody is below the water, is underneath, but where you can reach with your arm, then we use the duck practice. You just put your hand, and then you pull that person out. But also there is a scenario where somebody is deep down there, and then you need to use deep water submerged. Where you need to go for that person and then have aid. Why in modern life saving, in modern life rescue, they are saying don't go without a tool. And then there are tools which were designed for this, the rescue tubes. So you are advised to go with the tool, with the rescue tube, and then you have the tube within the chest, and then you come up with that person. So which is called the rescue. Yeah. So again, those people who are leading, not responsive, who are violent. Somebody. Yes, somebody who is aggressive. And you will find whenever we are doing this rescue, I gave you an example of the man who went to rescue, and then the first rescue, the first operation is good, and then the next. So there are challenging rescues. We say if the victim can be, some victims are unpredictable. Why they are unpredictable? Because of the anxiety, somebody is seeing death, so can do anything. I tell people, I saw a lady who was swimming with a 6-year-old girl, and when he felt like drowning, he grabbed the girl, her own daughter of 6 years. So these victims that are really unpredictable. That's why, because of the anxiety and fear, anything that comes, that's why we are saying they can behave in the way you do not expect them to do. So the approach can change. So we have what we call the aggressive victims. If you are unable to control them, we say, please use the push away method and you go until when you call. So once you see somebody aggressive, want also to grab you, we normally say, no, use that push away, during the aggressive victim, use the push away, just push that person slightly with your foot, push that person away, or with your hand so that he goes away and you escape. So call for more. Another is the multiple response people in distress. So normally you can have two people at the same time. Maybe one was trying to help a friend, or they were moving in the same canoe, the same boat, and then one got an accident, someone was able maybe to swim, maybe, but couldn't do rescue. And then now there are two. So we are saying, if you do not know how to get them, please call for other emergencies. And here I will also talk about the two rescuers rescue. What we do. Normally we say, we have a buddy system in rescue. We say, don't go for a rescue when you are alone. For example, if you see somebody in distress in water and you are alone, don't go there. We use a buddy system that if that person maybe mishandles me, then there is another person who will come to help me. So what we do, one comes from the back, for let's say for aggressive victim, one comes from the back and one comes from in front, so that we are able to rescue this person. Yeah. So then we have the on-scene management. Scene assessment, it's very important. Like before we do anything, make sure that the scene is safe. The scene is safe. The scene is safe. The scene is safe. Yes. This is the best life support matrix. And what I'll briefly talk about the care steps and the care steps and what can be done. More so, let's talk about the adults. So once somebody, the first step, scene safety. And for the adult here, we determine the scene safety, check for responsive and tap, tap whether that person, stimulate pain and see whether that person is responsive. So another will look at the victim position and airway, where we place the victim is back, tilt, and then we see the airways. Another one is assess. We stimulate the pulse and breathing, look for the chest and then look for the chest movement and then check for the pulse. But there is a scenario where the pulse present, it's normal, normal breathing, absent. Yeah. So there, if the pulse is not there and then the breathing is there, if the pulse is there and the breathing is not there, we give less to breath. And then another, if we have the pulse and then no breathing, normally we give compression, but it's a layer case. And then we'll go to a situation where we have no pulse, no breathing, and then full CPR. Yes. Another one, I will talk about the Dr. ABC. And then in ours, we have, next slide, in ours, we have the S there, where we call for help, send for help. After the danger, response, then we send for help. Because normally, people on the ground, the lifeguard, the rescuer, they are not real medics. So we put S there, which is sending for help. And then we make sure that the help is oncoming. So I will also talk about the best life support priorities, which are four general PLS care guidelines for we responders. One is to perform a primary check to assess the victim. And 2 is to provide early CPR. And 3 is to provide AED if available. And another one is to provide supplemental oxygen. So as we are doing this to drowning victim, we make sure that we do the early check and then CPR, AED, and then oxygen. We have what we call the primary initial check. And then here we'll check for responsiveness, in normal breathing, check for pulse. Is a must for somebody who is drowning. But we have also something common in drowning victims, which is vomiting. Most drowning victims, they do vomit. So it's better, normally what we do, and we advise other respondents to do, is to make sure that you put that person in the streamline position. I wish our presenter is able to make this slide so that these people see this. So we are on vomiting. So it's better that we put that, we load that person onto the recovery position, and we remove all those vomiters and make the airway really open. I talked about the victim with the pulse present but normal breathing, pulse present but normal breathing absent. I said that one breath every 5 to 6 seconds with a mask. We normally tell people to move with this breathing mask, and if no, in our normal setting, our normal setting, not everybody will have a mask. So I say, okay, if you find out that is that we call mouth to mouth, but because of the hygiene, it's a need not. So we tell them to have a mask, or else you can use this normal cloth and then save a life. So then we have where the pulse and breathing are absent or uncertainly, and then provide CPR. 5 initial breath. Why 5 initial breath for a drowning victim? Also, by the conclusion of the World Drowning Conference and the team that was researching on drowning, they realized that a drowning victim needs air, oxygen, and then that's how the introduction that on a drowning victim, we give 5 initial breath. But again, we continue with our 2, not 30 by 2, but the 5, not the initial, there are 5 breath. So we are looking at the multiple rescuer where the CPR is over there, then the chest compression, and also the ventilation, which I said it's very crucial. Then it's very important to have timely transportation. Has a rescuer, has a lifeguard, whoever responds to a victim, please, we normally tell them, as you see and you come across any drowning incident, the first thing is call the ambulance. That's why we have different numbers for these other responders, and then we are just assuming that the transport is on the way. There is something that we need to take serious, a takeaway. I'm just the last slide. Yes. What would differentiate somebody who has gone through our trainings to another? These are the takeaway. Prevention is the first step in drowning, because we don't wait for anything. Make sure that we prevent. And on-scene care, this is what we tell people. Until when you are safe, your safety, because it's more than my safety as a rescuer is also important as the one of the victim. So safety is very important. Also the skill, because you are now entering another world of water to get somebody from there. So you need to have the skill and the tools. We have been talking of a rescue tube. Whenever you are going for rescue, have a rescue tube. Whenever you are going, have something. Please, if you do not have the skill, do not have the tools, most times we advise you not to try. Rapid transportation saves a life. Just remember, you won't die if you don't know how to play football, but you can die if you don't know how to swim.
Oh, thank you so much, Mr. Moses Kalanzi. Apologies on the issues with the audio a bit earlier. I feel like Mr. Moses has attacked me with his closing statement as someone who doesn't know how to swim. I feel attacked, but yes, I'll make it a goal for 2025. So due to a little bit of the time, we're going to move on to the next presentation. You're going to still take on your questions after the next presenter. So I'm going to invite the next presenter, Dr. Michael Suuna. Yes.
So, okay, so I'm going to share my slide, my screen.
Dr. Suuna, as you start your presentation, as you work around time so that you're able to interact with the audience, we have 10 minutes to complete this presentation. Thank you. You can start.
Can you see my slide?
Yes, we can. You can go ahead and put it in PowerPoint presentation.
Okay. Thank you, Mr. Kalanzi. I'm going to take it on from where he stopped, just to emphasize a few points from a medical perspective. And this is regard to on-scene management, the pre-hospital care that is given to near-drowning victims. He mentioned that it is important if we are to rescue patients, we do it in a safe manner and preferably on shore and using tools, whatever we can have. Tree branches are very common in Kalangala and ropes, but if you have buoys or tubes, whatever you can use, please use it. Avoid becoming the second drowning victim. And remember that if in case you drown, you also further minimize the chances of survival of the patient. So please, please, please take note. What he didn't probably tell you is that sometimes depending on the skills, we can begin rescue in the water. The only thing we can do in the water is actually giving the rescue breaths. The CPR and pulse checks are almost impossible to do while the victim is still in water. Occasional rescue breathing is important, so always keep it in your mind. If in case, like in the case I presented to you, the patient was unconscious, but was transported, was moved from the swimming pool to the side. And all efforts should be made to ensure that this is done in a vertical position. You move the patient in a position that is vertical such that they do not aspirate stomach contents and do not take on water again. Cervical spine immobilization can occur only in some cases, like in cases of diving accidents or watercraft sports. In case this has happened, you need to make sure that you support the cervical spine as you move the patients to the shore. Keep in mind that there are so many studies that have done. One quoted is Spillman 2012 that actually show that cases of cervical spine injury are less than 1%. So routine cervical immobilization is usually unnecessary, but can be done based on the mechanism of injury. And that is diving, accidents, or motorsports. Now, if this patient gets on safe ground, dry land, the first thing you do is to call for help. He mentioned about the doctor's ABCD. The dangers are out. The next thing is to call for help, irrespective whether you are an experienced medical personnel or a rescuer, please call for help. A resuscitation you cannot do alone. So call for help. After calling for help, assess the level of consciousness. Okay? You are basically checking if the patient is breathing. And if they are breathing, you put them in a recovery position. If they are not breathing, that's when you begin the rescue ventilation by giving 5 breaths. 5 breaths. This is very, very important for drowning victims. It is a bit different from the standard CAB approach. Here we begin with airway, breathing, then the compression come last. Okay. So after giving the rescue breaths, you can do the compressions, 30 chest compressions to 2 breaths. And I already mentioned to you that we follow the ABC approach, not the CAB approach. How do you give these rescue breaths? You take a normal breath, press your lips over the mouth of the patient, and pinch the nose. Pinch the nose and blow until the chest rises. Take about 1 second, allow the chest to fall before you repeat. You see this? There are always concerns about infections, not giving mouth to mouth. People don't want to give breaths to drowning patients. Please give breaths whenever you can. In case you are too concerned, or if you have some devices, like this is called a CPR mask, you can use it. This has a filter here that can prevent the contamination that most people are always worried about. After the breaths, then you continue to the CPR. It is important to note that compression only CPR is unacceptable for drowning patients. A question that always comes about: when do you start CPR in a drowning victim? There is always a cutoff. Any patient who has been in the water for more than 60 minutes and has physical signs of death. Physical signs of death are things like rigor mortis, liver mortis, decomposition, or any physical injury that is incompatible with life. You do not start CPR. So it is important to always determine the duration of drowning before you start the interventions. And then, in case you start, when do you stop? You only stop if the patient is not feeling cold, they are not hypothermic, and they have been in asystole. That means a flat line for more than 20 minutes, and then you can stop the CPR. CPR technique. Good quality CPR is always very, very important. And this is how it is done. Your hands on the lower half of the sternum, in the middle of the chest, 2 hands interlocking, one over the other, with the elbows locked, and straight arms above the patient. Okay, you can see in this image how this gentleman is performing the CPR. Always compress for about 4 to 5 centimeters or 2 inches deep at a rate of about 100 and a compression to ventilation ratio of 30 to 2. So good quality CPR is very important, and I advise everyone here, especially health workers and the rescuers, to please practice good quality CPR technique. He mentioned that aspiration is always common and we have to anticipate it and manage it accordingly. They swallow water or the stomach contents. So depending on your setting, you could maybe roll them, put them in recovery position or have a suction ready and then try to keep them warm. In the pre-hospital setting, depending on the experience and scope of work, we can also do advanced life support. We can intubate patients. Some of them may need intubation if they have progressive respiratory distress or severe hypoxia. Now, also occasionally patients have, they could be hypotensive, but this in most cases, it resolves when we begin giving oxygen. But however, in case you give oxygen and the patient remains hypotensive, then you can consider the use of crystalloids by infusion or bolus or the use of vasopressors. Now, also, although most of the cardiac arrest rhythms that are observed on ECG are usually PEA and asystole, if the patient has a shockable rhythm on the ECG, like ventricular fibrillation, always plan to use the defibrillator. And commonly, people have the AEDs. These are much automatic external defibrillators, are much easier to use. They will tell you when to shock and when not to shock. In this case, make sure that you apply the pads on the chest that is dry and stay clear of the patient before delivering the shock. Studies have shown actually that 65% of patients who require breathing and 86% of patients who require CPR end up vomiting. So I still emphasize that you have to anticipate this and plan for it accordingly. Further protocols or ACLS protocols can be applied as in when needed, like for example, the use of adrenaline during the resuscitation. I leave you with these studies on cervical spine immobilization, but the take-home point is that the studies that have been done, about 0.5% of drowning cases that have a result of diving or motorized sport can have cervical spine injuries. So the point is they are really rare and they shouldn't delay. Cervical spine immobilization should not delay the resuscitation ventures. After this, in case the patient is able to breathe, we will transport them quickly, like he mentioned, to the hospital. If they are unconscious, but with a pulse, we can move them in the recovery position to the hospital. Or if you anticipate vomiting, then you can prop them up as you transport them to the hospital. The mode of transport sometimes is determined by the level of consciousness and the availability of resources. Most commonly, people transport these using private vehicles, sometimes in sitting position. Whatever is comfortable for the patient and safe, we will transport the patient accordingly. I'll take in any questions that you probably have at this point. Thank you.
All right. Thank you so much, Dr. Suuna. For the questions, I think let's continue putting them in the chat. We are going to respond to all of them together. So he has given us a brief management on-scene management and how to transport this patient to a health facility. So we're going to have Dr. Clare Amare come on and tell us how about the in-hospital management of near drowning. So I'll invite Dr. Clare. Oh, she's giving us another case on how they managed a near drowning patient. Okay.
Good afternoon, everyone. I am Dr. Emuron Joseph. I am going to take us through our second clinical presentation. It is a case of still near drowning, but in a 2-year-old. So as we wait for the slides to be projected, let's just reflect on what we've so far had. Do you know how to swim? Are you able to rescue a person that is drowning? Should you even rescue a person that is drowning? So that should be something that should be running in your head as we are waiting. Okay, so since they're projected, this is a case of a 2-year-old female infant, a referral from Alua facility who presented with a 2-hour history of difficulty in breathing that was associated with fast and noisy breathing. This was following an accidental fall into an incomplete latrine pit about 6 feet deep containing rainwater. Was found unconscious. However, there's no history of convulsions or fever. She was assumed to have spent less than 10 minutes in the pit. So as we did our primary survey at the receiving facility, the airway was opened, though it was threatened. Our patient's level of consciousness, as per AVPU, she was responding to pain. So when we went on to breathing, she was tachypnic with a respiratory rate of 67 breaths per minute. Also hypoxic, the SpO2 was 72% in room air, had nasal flaring, head nodding, grunting. As per auscultation, she had subcostal and substernal retractions. Then on auscultation, she had bronchovesicular breath sounds and diffuse crackles. As per interventions, initially we put her on oxygen therapy, but since that did not alleviate our symptoms, we transitioned her to local CPAP, the bubble CPAP that you make using a bottle. As we went on to circulation, our pulse rate was 112 beats per minute. She had central cyanosis and had cold extremities. At this point, we gave IV fluids, we gave normal saline. Well, that is just a picture showing us how to make the bubble CPAP. This could be very helpful when you get a patient with difficulty in breathing. Yes, we go on. Going on with our primary survey on disability, on AVPU, she was responsive to pain. Our RBS, the random blood sugar, it was 15 millimoles per liter. She was hyperglycemic. Though there were no focal neurological lesions seen, and she had her pupils were equally reactive to light. So our intervention, we placed her on recovery position. On exposure, the temperature was 35.2 degrees centigrade. She was hypothermic, and we covered her with warm clothing at that point. So moving on to secondary survey, our head-to-toe examination. On the head and neck, the abnormalities seen. On the chest, as noted earlier, she had subcostal and substernal retractions with diffuse cause crackles. The upper limbs were normal. We go on. Yes, on abdomen, it was mildly distended with the hypertympanic percussion note. The genitalia was normal and the lower limbs were normal. Yes, on our sample history, on signs and symptoms, as noted earlier, she had difficulty in breathing with loss of consciousness. No known allergies, was not on any medication. No past medical history or past surgical history. On family social, she was the 5th born. She was the last born to peasant parents. And her last meal taken that day was lunch. So since they came to facility at about 7, so her last meal could have been 6 hours prior to admission. So the events surrounding the incident, she accidentally fell into an incomplete latrine pit while playing with her siblings. So we generated a problem list, and one of our problems were respiratory distress, hypoxia, hypothermia, reduced levels of consciousness, and a mildly distended abdomen. The recommended investigations, we recommended a chest X-ray, serum electrolytes, brain CT scan, cervical spine X-ray, but none of these were done given our limited resources. Yes, so on our differentials, we had near drowning complicated by aspiration or chemical pneumonitis, and acute respiratory distress syndrome. We're also ruling out injuries, possibly to the spine or head injury, and severe pneumonia. So on management, in addition to what we did on primary survey, we gave the patient IV fluids. These were really maintenance fluids. Since the patient was unconscious and was not taking in orally, those maintenance fluids was put on oxygen therapy via nasal prongs, but later on transitioned to CPAP. We gave IV ceftriaxone. Someone would ask why. We gave it prophylactically since we cannot do we can't do sputum gene expert, we cannot do gram staining, we can't do cultures, so it was really given prophylactically. The hydrocortisone, I gave this in anticipation of inflammation because I'm not sure of what the patient aspirated, whether it was a chemical or just clean water or water infected with the bacteria. That is why I gave the hydrocort. We kept the child warm and continued monitoring SpO2. So on follow-up, this patient was followed up for 5 days, and she displayed the progressive improvement, was weaned off oxygen by the 3rd day, and the levels of consciousness improved. And by the 4th day, the child was active and alert. So our disposition plan, we allowed the child home on the tabs amoxicillin, and we gave her a follow-up appointment date. We also did health education on the parents on when to bring the child back to the facility, and also on how to prevent further incidences from occurring. Thank you. That's the end of my presentation.
Okay, thank you so much, Dr. Claire. And I'm going to invite Dr. Joseph Emuron to kindly continue the presentation on management of a near drowning patient in hospital management. Thank you so much.
Thank you very much, moderator, and thank you very much, our previous presenters and the audience online. So we're going to have a discussion on drowning, and basically this topic was environmental emergencies, and in this case we're going to look at drowning and near drowning. So I have an outline, and I'm happy that my colleagues have actually addressed some of the issues. So I'm not going to take very long. That's the outline. We'll have definitions, epidemiology, pathophysiology, as you can see. And next is this is just environmental emergencies. So drowning is one of the environmental emergencies. However, we have many other environmental injuries or environmental emergencies. And this usually come when you have a sudden onset of disaster or an accident. And we know that an emergency occurs when something sudden occurs and then that thing is life-threatening. So we have different forms of environmental emergencies in our setting, but also in some other settings. So, but for today, we are going to concentrate on drowning, and I think we've already covered some of them, like snake bites. I think at some point we did burns, electrical burns. So on that list, those are some of the examples of environmental emergencies. Next. Yes, so I want to make this very clear. So from today onwards, we shouldn't be using the word near drowning. So traditionally, that was before 2005, we used to use different terms: drowning, near drowning, wet drowning,
dry drowning, active drowning, passive. There are quite so many terms. And they were kind of confusing and they're not making any sense to the management of the patient. Or traditionally, we used to define drowning as when someone gets submerged and dies within 24 hours, and then near drowning when they make it more than 24 hours. But it was not catering for the outcome. So clearly in 2005, the World Health Organization came with a policy, and it was agreed that we scrap off all the other terms, and now we use the term drowning. And that was to improve documentation, but also now in terms of outcomes, when someone has drowned, you have 3 outcomes. So either someone dies or becomes morbid, or at all there's no morbidity. So those are the outcomes you can track with patients who are drowned. And my colleague defined drowning, and the definition is there. You experience some sort of respiratory impairment, then you get submersion or immersion. It's important to know those 2 terms, submersion and immersion. And submersion means your airway is below the water. Some of you have swum, so the water actually is at your neck. And clearly, if you've done that, you'll feel that you'll have some sort of difficulty breathing because you have the water pressure kind of making it difficult for you to expand your chest. And then when we say immersion, it means even your face now is actually covered up. Yes, we go on. Yeah, in terms of epidemiology, we've come a long way, but the recent statistics from World Health Organization puts it at 3,000 cases reported annually. No, that's worldwide. And most of the people who die from drowning come from low and middle income countries. And disproportionately, more children and young people are seen to die. However, there are certain instances, like if there is a disaster, let's say earthquake or volcano, flooding, the people who tend to die more are elderly, and we understand some of them may not be able to move away faster. And the age group affected, we have children between 1 and 4, and then 5 and 12, and then of course elderly. Those are the more affected ones. And from the year 2000, they came up with some sort of action, again, plan for drowning. And we've seen that from the year 2000 up to 2021, drowning has reduced by 38%. And I would say for Africa, it was put that it has only reduced by 3%. So we still have most of these cases. So the picture on this side tells you globally, where do we see, where do we have these drowning cases? So you can see from there, we have the yellow one, which is the West Pacific, and then the green one, which is the South Asia, and then Africa, we have 23. So the others, the Europe, like high-income countries, there are really very few cases of drowning. So drowning is a big problem, and my colleague alluded to that. And let's take a look at the Ugandan picture. So this study was published by someone from Makerere University, and what it actually did was looking at understanding and preventing drowning in Uganda. So they looked at around 60 districts, which are lakeside, the ones which are near lakes. And if you look at that slide on this other side, can clearly tell you the district with the highest number of drowning. So Kalangala was among the top. And I had my colleague here, he told us that Kalangala actually has Dr. Suuna, and then Kalanzi. Kalangala many cases, then Kampala. So most of those districts near. The ranking comes as below. You can get this study online. But again, if you look at the sex, more men actually drown as compared to women. And if you sum it all, in Uganda alone, we had like 2,000 cases. And I would say one of the things this study brought up was issues relating to data. How do we capture the data for drowning? And we found out that they found out that there were inconsistencies in reporting these cases. And this is just what was reported, but also we have those cases that actually die and they get reported nowhere. All right, so move to the next slide. So risk factors really, the age you saw, the age groups 1 to 4, and let me say in terms of drowning, we are just thinking about the water bodies, but also there are certain things at home where children can easily drown. One of them is if you have buckets, tanks and whatever, especially children who are like less than 1 year. Those are people who can drown in those small things containing waters at home. And then, of course, that age group, 1 to 4, they are curious. If you have pools which are open, they can get them there and they can easily. And I like this other case, second case, you had someone had a pit at home and they had collected water, someone drowned. So in terms of sex, we've seen that more males, because of what males do, many of them are fishermen. And then also occupational exposure, people who are into boats, fishing around the lakes, whose work is related to water. And then, of course, climate change, what it can do when the oceans melt and flooding comes. And then transport, migration, we've had refugees. What I would want to say from the other data, the data we saw does not account for people who die from this transport or the ocean, crossing the ocean, or these disasters. It was pure like data got from the hospital health facilities. We can continue. There are other factors, and I want you really to pay attention to this slide. There are sometimes some people can actually drown because of another existing condition. And this is really true for people who know how to swim. If someone really knows how to swim, but from now they say, hey, someone actually drowned. So it could be that someone is intoxicated or has taken some drugs, someone has developed some sort of syncope. You can actually develop syncope when you get into a pool. Normally, what happens when you get in with that cold water and then holding of the breath, the vagus nerve is activated, and what it does is to slow down the heart, and you can actually get syncope, and then you drown. And then the other things could be seizure. Someone who has seizure disorder is next to a water body, they can easily drown. Cardiac conditions, some people have walking with some arrhythmias and they can suddenly collapse, and if they are next to water, things like dementia for the elderly. But the other thing also we have to be sometimes look out for is things like intentional suicide, someone just gets into the water, homicide, someone's killed and thrown into water. That's why I'm happy someone brought out the other person. They try to look for signs of injury or someone. It could be someone that has eaten someone. And then the other thing for children, it's important for us to look out for signs of child abuse and neglect. You have to pay attention to the story they present. Does it make any sense? Then, of course, the other thing colleagues have brought it out is injuries associated with drowning. So especially if they are shallow water, someone can drop in there and get head injury, spinal injury, and maybe some other, long bone, some of the injuries. And of course, the other things is hypothermia, aspiration, respiratory failure. Those ones to find out. Next. Okay. This is about the pathophysiology, what really happens in the process of drowning. So normally, of course, with one thing that someone accidentally gets submerged in water. And when you accidentally get submerged in water, what happens really is that you get so anxious, you will start panicking, and then you feel like you are going to think of holding your breath. Like you're doing this voluntarily, but then as you're inside the water there, that voluntary holding is not going to hold. Accumulation of carbon monoxide, then hypoxia, all these factors are going to drive you to kind of open your mouth and then open your airway. And in a way, you're going to actually swallow some water, but also some water is going to to the air, you're going to aspirate some water. And what the airway sometimes does is to trigger laryngospasms. And the reason it's doing that is to kind of stop you from taking in some water. And it's really important for you to know this. There is going to be very little amount of water needed for you to kind of, your alveoli to lose, to collapse. It's about between less than 4 mils per kg of fluids. And so that small water can actually cause a lot of trouble in your airway. So what happens now when water goes into the respiratory system? Of course, it goes to the alveoli, surfactants loss, the alveoli collapse, the PQ mismatch. You know that air migrates from alveoli to the blood vessels before it's taken. So all that barrier is going to swell, and you're going to have less oxygen going the other side, and you're going to have hypoxia. And then now, hypoxia, you can't even breathe out, hypercapnia. What happens if you have hypoxia? You're going to have, you switch from aerobic to anaerobic respiration. So you're going to generate lactic acid, lactic acidosis. And when the more time you take and you generate those components, that's actually going to affect so many other organs in your body. So with the drowning, something that really causes a lot more damage is the hypoxia. You're going to be asphyxiated. There are two other important things in that slide. That's diving. There's something called the mammalian diving reflex. So this is what he thought. When you get into water and then cold water, what I was explaining, in some cases you get the sympathetic system, the vagus nerve stimulated. And once that is stimulated, the vagus nerve, we know that its purpose, it slows down the body. And this is thought to be some kind of a protective mechanism. So you're going to have most of you're going to have the slowing of the heart, and blood is going to be diverted just to the heart and the brain. And that is thought to be one of the ways some people protect themselves when they are underwater. But evidence is refuting some of this, because they say when you get in there, you get anxious, and the sympathetic nervous system actually takes on. Then the other thing to know, when you're submerged when your body is completely in the water, what is the effect on the cardiovascular system? So there is some sort of pressure, hydrostatic pressure of water. It's kind of compressing on your tissues. And under the skin, we have the veins. So it's going to actually increase some venous return. More blood is going to the heart, and then it kind of increases the output, the cardiac output. But this is important because they say that when you're bringing someone out of the water, you have to bring them in an horizontal manner, not like in a vertical. Why? Because the moment you bring them out, these other vessels are going to open, and then the blood is diverted back to the peripheries, and then someone gets saturated with collapse, something like that. Okay, let's go on. All right. So in terms of clinical assessment, when this patient comes to the emergency department, we have the normal approach, but I just want you, these are things that should come out in your history. The timing, how much time did someone spend? And we had that if it's more than 10 minutes, the more time someone takes, the more likely someone is to survive. So less than 10, they are likely to survive if other intervention came on. The time and then the treatment. Also, from the time they go down to the time they started the treatment, what I was saying, CPR, and my colleagues have talked about that. And then also, what time did this person really take to regain their respiratory effort? And then the other thing, what are the circumstances around drowning? Homicides, child abuse, those things should try to come out. Then the water, was it deep water? Was it fresh? Was it muddy? Sometimes some people drown in sewage. Then there's another thing, fresh water and then salt water. Someone can drown in either. There is no difference in the way we manage the two, but there are some theories around that. That when you swallow salty water, it's going to pull the water from your body, and you're going to have like hypovolemia. Whereas if you swallow fresh water, it's going to go into the system because it dilutes and some aspect of osmosis. But as of now, there is no difference in the management, whether it's fresh or. Then precipitating factors, we talked about this. You should try to look out for this, and also once you find, you should be able to manage them. Continue. Of course, when you examine your patient, you do the general, but then you focus on the systems. And the systems, the key system here is the respiratory system, which you're going to look out for signs of respiratory compromise. Respiratory rate, the distress, the cyanosis, the crackles, the wheezing, and all those. Then cardiovascular system, we know you do your assessment. What is the rate? You saw the other patient had the atrial fibrillation. It was very important to palpate the pulse rate. And when someone drowns, the heart is going to go through different rhythms until it actually stops. The last one is that. Yes. And then evidence of brain, the CNS, your CNS. So hypoxia is very sensitive to two organs, the heart and the brain. So
Can you hear him?
Yes, it's back.
Can you hear me? First go back. Oh, yeah, continue. So investigations, there are a number of investigations that you can do for drowning patients, but most of them are not helpful. And also, of course, some of them are expensive and really depends on the setting. In terms of the laboratory investigations, you can do the random blood glucose because we know that someone who is a hypoglycemic can actually collapse if they are next to the water and also drown. Then the other thing you could do is the ABGs. I don't think very many centers do this, but ABGs can tell you, the oxygen levels in blood, but also can give you an idea about electrolytes. A CBC, you can do the CBC. You might be able to pick out some other maybe underlying abnormalities. But in terms of infection at that very moment, there's nothing much you'll be able to get. Then you can do RFTs and serum electrolytes. So normally what happens when you get the other complications of hypoxia, it can actually end up giving you an organ damages. So some of these tests will be looking out for those organ damages, although they may not be there immediately. If you can do this serially with time, you'll be able to pick them up. Coagulation profile, actually, one of the things that can get affected, especially when you have hypothermia, is your coagulation profile. You may have this elevated. And then blood cultures, these ones also, you can take them. Many centers may not be able to do, but basically you'll be looking for infection and might give you more results when you do them later. And then a toxicology screen, alcohol, for instance, creatine kinase. We have seen one of the complications of drowning is actually rhabdomyolysis. And this comes in when cells die and then start releasing myoglobin. Then that can come in to the system. But also in cases where we have like crash trauma, someone was traumatized and then gets in there. Then, of course, radiological, this, one of the most important tests I would say is a chest X-ray, because we know drowning mostly affects your, and I mean, the airway is a start. So that will give you a picture of what's going on. So what things you look out is, you know, shared opacities. And there are other complications people can do. One of them is pneumonia. The other one is the ARDS, acute respiratory distress syndrome. This one, you will pick them up. Of course, a CT scan, you might also need it in case you're highly suspecting spinal head injury. And of course, POCUS, if you have POCUS, that is point of care ultrasound scan, it can help you with you know, getting to know what's going on in the lungs. ECG, that and the ECG monitoring, this is really important, especially when you're, you know, you have signs of, you know, arrhythmias, and some of these people could be having underlying problems which are kind of known. And then EEG for seizures. Continue. All right, so now what happens? Let's say this patient has now arrived at your emergency department. Of course, most by the time they come to your whether emergency unit, wherever you're able to give acute care. So you have some goals, and we know that the systems this drowning affects airway, breathing, circulation, and the others come as a result. The CNS is going to be destabilized because someone's having hypoxia. Unless maybe they had some other thing before, maybe a stroke, they got a stroke or something. But even stroke is in circulation. So support your airway, support your breathing, support your circulation. That is one of your goals, to support those three systems. And then stabilize the body temperature. That is, you have to find ways to rewarm your patient. But don't be aggressive. Actually, they say you keep these patients in the moderate, mild hypothermia, so that it kind of slows down the consumption of these things. That can buy you time for the patient to recover. And then prevent secondary brain injury. We say that hypoxia is the primary insult, but the rest of the other things come from that. So you got to prevent that. And so if I have 9 patients in emergency, they show up in wherever emergency unit, your clinical room, wherever you can be able to resuscitate patient, you're going to use the ABCD approach. And my colleagues have already talked a lot about CPR and ALS, how you run a code in case they have arrested. I'm not going to spend time on that, but I would like to add that when you're doing a CPR on these people, with a mind, you're resuscitating someone with hypothermia. In this case, you've got to think about, bringing them to mild hypothermia. And then if they consistently have a systole for a long time, then you can easily give up. But also there are many factors that determine for you to be able to. You might be alone or very few people. So you use the ABCD approach. The other thing with hypothermia, it might be very difficult for you to get a line. Even then, when you're shocking these patients with AED, you have to be very careful because you have water and whatever, and the electricity with water is not good. Next. So if I have my patient and I have them on my trolley, I'm going to go through the ABCD assessment, just like someone did, Dr. Suuna did it. So you're going to assess your airway and check whether there are secretions or not. You can suction the secretions, position with airway maneuvers. But what I would say, do not attempt to drain water. There is a tendency, I've seen this in villages. People say, over you step on the tummy, first push out the water, step on the chest, push out the water. That actually is going to take cause more damage. And you cannot actually get in to the lungs to push out that water. So remove what you can if you have the suction. And remember the C-spine. If you have that from the history, most times you'll get a glimpse of this patient from the person bringing them. They will be able to provide you with some information. Then you come to breathing. This is really, really, really key. We know that the primary result is a hypoxia. So make sure that your patient you give your patient oxygen and give it like maximum. Look for the maximum device to give them oxygen. provide them with 100% oxygen. So we have different delivery devices. If I had an adult and they have drowned, I would want to start them with from a non-rebreather. Then if they are constantly there for a long time, I can de-escalate. Don't start from something very, very small. And the monitor the pulse oximetry. You have to consider continuously monitor. But again, know that this patient, if they have a hypothermia, they might affect your, picking the pulse oximetry reading. It might affect that. And the other thing you have to be aware of aspiration. So you have to think of NG tube. And in some cases, maybe if someone was in mud and whatever, you've done examination, no air on one side, and you have ENT, you might be able to do the things like bronchoscopy. Then consider CPAP. We've had the other child, they tried with this other nasal prong, but it was not working, so they gave CPAP. We know that when water gets into the alveoli, it reduces surface tension, and those alveoli just kind of close. So when you give CPAP, you're giving a positive airway. So it's going to help you keep those alveoli open. If you can switch to CPAP, if you can make one, or if you have one, do that. If someone is not improving with the maximum level of oxygen you can deliver. And then intubation and mechanical ventilation. So for patients whose GCS is less than 13, and they having a poor respiratory effort, they are not conscious, they are not coordinating, they are working so hard. So these are patients who qualify for intubation. And really, when you intubate this patient, your primary goal, you're oxygenating them appropriately, like well, and then you're minimizing the risks of getting lung injuries. And of course, also the other thing you've got to be thinking, with positive pressure, a lot of it you can also affect the cardiovascular system. Then bronchospasms, in some cases you get bronchospasms. If you think the bronchospasms are there, you can use nebulized bronchodilators. Then the other thing also we've seen is positioning. Some of these people can actually develop ARDS, although ARDS may not show, it doesn't show immediately. It normally comes in after some hours, 6 hours, like that. Positioning them well can help. Antibiotics, it's some literature says there is no role of antibiotics in fresh. Okay. Hello. Thank you. Sorry, we got a technical problem, but I was going through your breathing, what sort of things you'll be doing. So I said the priority is the oxygenation, and try to give the max. So make sure that you maybe keep your patient, especially the part where you're going to put your pulse oximeter warm it before. I talked about the CPAP and CPAP and intubation with mechanical ventilation, where I say that for those patients who are not improving or with the maximum amount of oxygen, try to switch them to CPAP, because CPAP provides that positive pressure which will keep the alveoli open, and so that will improve the oxygen can easily diffuse and get to the bloodstream and will reverse some of these complications that are coming on board. And then, of course, intubation, you intubate your patient, especially those with the low GCS below 13, and then their patients are really in severe respiratory distress. They are not able to breathe well. So those are some of the things you consider to intubate your patient. And then bronchospasms, if you think they are there, use nebulized bronchodilators like salbutamol. And then in some cases, you may need to prone your patients. It will actually help open up some of the areas where air can easily get into the lungs. Antibiotics, there is a bit of a debate. Some people say don't start antibiotic, but depending on the circumstances, really. If someone drowned in dirty water, mud, sewage, and you're not sure, and sometimes your context dictates. So I would think you can give a broad spectrum antibiotic. And then the other thing, some people aspirate. You also know that when some people aspirate, they aspirate, things, gastric contents, it might be useful to add the metronidazole. There are studies that have, some people have used surfactant. This one, I don't think you have it in Uganda, but just know that you can also use surfactant, especially in cases that are severe. There is limited evidence. I only saw like one study where they had given some patients and there was actually an improvement. So I think some people might think of furosemide. I haven't seen furosemide in any recommendations. So don't think of furosemide unless otherwise. Again, the context of your patient, maybe they had heart failure or something like that. Next. Of course, after the respiratory, you said airway, the breathing has a lot of issues and you go to fix that. The next thing is the saturation. And because they can arrest from outside, but also they can still arrest within the emergency department. And just like the other colleague said, we use the ALS guidelines to manage the arrest. But in this case, we think about arrhythmias, and again, monitoring this patient. If you have an ECG monitor, I know some centers have ECG monitors, but they don't know how to use. Try to learn how to use them. If you have hypotension, which can occur in these patients, try to give your fluids, but give cautiously. Remember, some of them are having maybe lung problems, and the moment you give more fluids, it's even worse in the lung. But also don't restrict fluid because you know that this person has problems with the lung. These are two separate systems. Your assessment guides you. Someone has hypertension, give them fluid 20 mL per kg body weight, and then you reassess your patient. And correct, if you have some form of arrhythmia, see how to manage the arrhythmia. And usually, this arrhythmia is due to hypoxia and all those. Once you correct the hypoxia, number one, and then you give them a bit of fluid, and then you rewarm them, most of the time, they are likely to improve. Vasopressors, you can only use them in cases where you've given some bit of fluid and you've corrected oxygen and the other and still not working. You can give a trial for vasopressors in that case. Electrolyte imbalances are really not common, but they can occur, and they usually really come because of that damage from hypoxia at a cellular level. And in your disability, of course, you're going to check glucose. If a problem is there, you can correct. And pupils, again, that might tell you, for instance, if you have anisocoria, one side is dilated. Maybe that might be a guide to you that maybe there's head injury going on in this patient, might need a CT scan. And then you might get pinpointed pupils. Maybe someone was in an opioid. You know, those are things that guide you. And look for, you know, if you had, this is in this time when you're assessing the disability, you can find that. Then exposure, of course, what I'm thinking about is from head to toe. Then you manage your hypothermia. In our setting, the easiest way is, I think, you know, remove all the clothes, you know, try to dry your patient, then cover the blanket, give warm fluid. There are other methods, there are other ways you can manage hypothermia, but I think in our setting, those are the easy ones. In advanced setting, you can have some, you know, air bath, and people blow some sort of warm air. In our setting also, I see people putting, they can warm normal saline bottles and put them in different points. The other ones are centrally. You can put a central, you know, line, and then they can manage hypothermia. Okay, so then the other thing, you look for the complication. Was it seizures? If the seizures are there, manage seizures. What was the triggering factor? Given the precipitating factor, depending on what it was, and depending on what you find in your patient, you will manage that. Because if you have head injury, you will manage the head injury. And I think we did management of head injury last time. Continue. So how are you going to determine who is going to survive, who is going to not going to make it? From the literature, some guidelines say 95% of people who present with the pulse if they came to your emergency department with a pulse or wherever at the hospital, they are more likely to survive. But if someone came without a pulse, I mean, they are arrested, the chances are very low. Then some evidence puts it at 7 to 11%. So just not like 93% of these people are not likely to make. And you don't know at what time did they arrest. You know, there is no witness. So in that case, it is very difficult. That's why out of hospital management, these people, you know, bystanders would rescue us, and then they start early CPR. That really helps a lot. But these are some of the factors that determine whether someone is going to do poorly or do badly. So if someone has have been submerged for more than 5 minutes, actually there is conflict. People say 5. Some people say more than 10. So it depends also on the setting, and if you're in places where people can do, you know, serious resuscitation and they have ICU critical care services, you might increase your chances. But then if you know you get someone with fixed and dilated pupils, GCS, very low GCS, like that's 5, acidotic, hypotensive, those are some of the poor prognostic indicators. And then the good ones, you can see them below. You know, young people, CPR was done on the field. CPR lasted less than 25. Detectable pulse on arrival, core body temperature less than that. And then the temperature, we know when someone has a lower temperature, it reduces the metabolic needs, and that sort of helps conserve. Next. This is just a summary. This now summarizes everything we've talked about. Someone has been submerged, the pre-hospital care, what do you consider? You know, that cautious rescue, as he spoke, cervical spine precautions, CPR, transport, and then oxygen. And the emergency department, airway, breathing, circulation, address any, you know, problem, determine the GCS. It's all there. And there are 2 tracks. You can go decide where the GCS is less than 13, and then this is where greater than 13. So I'm not gonna go through all these. You can be able to get this through the PowerPoint, and they are basically things that I talked about. Next. This is important, complications. So what are sort of the complications you can get from drowning? So I would say respiratory complications, then, you know, things like laryngospasms, pneumonia, acute lung ARDS. And then cardiovascular, you get things like arrhythmias, ischemic cardiomyopathy, having a CNS, then of course, different organs, because of hypoxia, you can get renal failure, rhabdomyolysis, DIC, hypothermia, electrolyte imbalance. So there are quite many, as you can see from there. I would say the most common would be things to do with the first airway, and then the brain, because those are the ones that are very sensitive to hypoxia. Then the brain, the lungs, the heart, the brain, and then others now come in. Yeah, disposing your patient. Where does your patient go? So when you receive the patient, you will treat them, you will monitor, at least treat, monitor, and observe them for 6 to 8 hours. Of course, this is case by case. As my colleague said, that in some cases, someone has come out, even at the field, you have to determine if really someone is talking, they spent a short time, someone was there, and in those cases, you may allow, but the advice is monitor them for at least 6 to 8 hours. And then there are different factors, of course, that determine that what was in the story. Did they have a precipitating factor? Where do they stay? Do they have someone who is responding in case they develop a complication? Because when you're discharged, if you're to discharge them, you're going to give them instruction that in case A, B, C, D happens, come back. Yeah. So then the key question you have to ask for discharge, not discharge, is this patient asymptomatic or symptomatic? And when you say asymptomatic, it would mean that almost all the systems are okay. Talking, well coordinated, GCS 15/15, the breathing well, no, not tachypneic, no abnormal sounds, airways is okay. When you take your SpO2, it's all right. Someone is able to talk, walk around. So, but if you have any of those things, these people are diagnosed, Bracos, whatever, they're having low GCS, another associated factor, those are the people you keep around. And all the intubated patients, we send them to the ICU. Yes, continue. So I think it would also be important for us to say something small about drowning. I mean, prevention. My colleague has done a lot, and so things like it's important education. So he said if you don't know football, but swimming can clearly you might need it at someday. So learn swimming, learn CPR, learn drowning risks. And these things you have learned, teach them to someone else. Teach your children. Then supervision, really important. Supervision, whether children at home, supervise them. Transport these vessels and whatever, pools. Yeah, they label them, some of them fence them off. And then, of course, equipment, safety and equipment. So if you're going to maybe traveling, a jacket, then cover pits, fence certain places where you think that can happen. So those are some of the things that can help us prevent drowning in our communities. And next. Okay. So the take-home messages here is that I want you to know that with the drowning, think about hypoxia, and you put it well with the CPR or whatever. The moment you remove someone, the first thing you're thinking about is hypoxia. That's why you give the 5 rescue breath before you start in the CPR. Manage your hypoxia, cardiovascular. Most of the time, that will help the other systems that are failing. And then look for evidence of precipitating factors and injuries. And also know that very little water can actually affect destabilize your respiratory system. And then there is this thing, Heimlich maneuver. Some people think that, as you want to push the water. So don't do that. That is not recommended. And then there is no there is no difference when you're managing someone from fresh water versus someone from salt water. And the steroids play no role in that. Unless otherwise, maybe someone had asthma. Of course, patients differ, honestly. Thank you very much for listening. We welcome your comments, questions. We want to learn what are some of your things you're doing in whichever areas of Uganda you are in.
Right. Thank you so much, Dr. Emuron. I believe it has been a very educative session. Due to the fact of time, we're just going to take some 2 questions. I wrote down some question for Mr. Kalanzi from earlier. What is the 10/20 protection standard? And the last question is, do we have water rescue training programs in Uganda? And do these rescue skills apply to drowning in cases of lakes or only to swimming pools?
Thank you very much. Yes, I will start with that. We have these training centers. Yes, at SwimSafe Uganda, we do have those trainings. Yes, if somebody can get us, who goes to get the contacts, we deliver those trainings and they apply to open water. So there are shallow water life-saving trainings and open water life-saving trainings. So the courses are here and they apply. Then 10/20. That means half of your energy or of your support must. There is a photo which was displayed and you could see somebody supporting. So that means you must be supporting that if you give, if somebody is pulling you, you have enough resistance, you have enough support. Next time, if given an opportunity, we'll demonstrate it. We can learn a shorter video, 2 minutes, and people understand this. Thank you.
All right. Thank you so much, Mr. Kalanzi. I personally will be one of the students very soon. Okay, for Dr. Emuron, on the chat, I kept seeing people kept insisting, how do we manage that hyperglycemia? Some people were like, 15 is too high, should we manage it? So in your case, should this be managed or it should be taken as part of the body's response? And then my last question was, you mentioned there's a bit of a shortage of surfactant in the Ugandan market. It's available, but I do know it's quite expensive. Goes for, I think, about 1 million. And that's just like a single dose. And if you give repeated doses, you can guess how much it would go to. So someone asked, can we use caffeine like we use in neonates as a substitute for the surfactant?
Thank you very much for those questions. The first one was about hyperglycemia in the other child. So this is how I would do it. So that was the index reading when they did the sugars. And of course, we know body response to any sort of stress or traumatizing event is going to mobilize sugars, and your sugars will go up. But also in the hypothermia, in the drowning, the fact that you might get hypothermia. So again, hypothermia kind of creates conditions in the tissues which do not allow the tissues to take up glucose very fast. So in this case, you wouldn't rush to manage, hyperglycemia. You first correct all the other issues around hypothermia, and then routinely take the glucose. And then if it's persistent, you can even go ahead and do glycosylated hemoglobin to establish whether this person was earlier on having some sort of hyperglycemia. So that's how you could approach. I have seen this, especially, like patients with the head injury. They can initially have a very high glucose.
But also sometimes some of these people receive some sort of treatment. Maybe they receive something related to sugar, and then the sugar actually shoots up. So those are all the compounding factors that you can look at. Yeah. So the next question was about surfactant. So the evidence says that surfactant is not something you should be very much concerned of, but it's a nice to have. There are really limited studies. I only saw one study where they put like 6 people on it and they actually made it. But aside from that, I not see another evidence. So your question was, is it okay if because of the price, is it okay if I used caffeine? Honestly, I haven't seen, I don't know much. I don't know whether that will work or not, but I would think would your patient prioritize these other things which you have control, correct the hypoxia, correct the, maybe hypotension if it's there. Correct, first of all, those other things, give antibiotics, if you can get them to ICU or whatever, if they are really very sick, then that will be fine. But for those who can be able to afford, yes, if that one study really showed that it actually works.
Okay, so thank you so much, Dr. Emuron. Kindly, let's also fill in the poll and the post-test. Please, it's available. Just go under the poll and you can go through the poll and the post-test. Any questions, any remarks from the session? Kindly, let's look at that through the poll. As we go through the poll, I see there is I'll have one person from there's a raised hand from Chirabo Mika Frederick. Maybe you can ask your question as people respond to the polls.
Okay, greetings everyone. I appreciate the entire team for these efforts. I don't have a question, but it's just a concern that we raised through the WhatsApp group of recent. Most of us have been attending fully to the CPDs and even registering in the link which they provide here. Unfortunately, we have always missed the CPD points. And we were complaining, we did everything in the right way, filling the forms, but because I think there is some mistake in the system that our numbers maybe in allied doesn't begin with a letter. It's just a plain figure number. And we always fill in, but I'm missing out the entire year's CPDs for last year, and it is very bad for me. So I don't know if there is a way you can help us recover, because I know you may be having a record of those who attended, so that for us who are after, you can raise our issues and get a way of seeing how you can help us to get those CPD points. For the entire last year, we missed out. Thank you.
All right, so thank you so much, Chiravo, for your concern. And it has been noted, and the administration has promised that they're looking into it and they're going to follow up on that decision. Thank you so much. So due to time, allow me to wrap up this session. First of all, by thanking all our panelists. Thank you so much for making this a wonderful discussion. We have learned so much. And I hope we do not step on our patients' stomachs anymore. And we're going to be better healthcare providers from this session. Thank you so much. And for our participants, this is only made possible by your attendance. So thank you so much. And we look forward to seeing you again next week. Thank you so much. Maybe before we all exit, let's all put on our videos and we take a group picture. This is the new version of group picture. So let's all put on our videos and then we take a picture.
Please enable it.
Yes, they are now enabled.